This is Carol from the STS. This is the General Thoracic Surgery Database monthly webinar for March. It's March 8th, 2023. Leanne's not able to join us today. She is traveling to the General Thoracic Club meeting, which is down in the Florida Keys. And so I'll be leading the meeting, and then Ruth has some really good education for us in just a few minutes. Again, please make sure you enter your questions using the Q&A, and we can go ahead and get started here. On the line with me, we have Ruth Rowley from STS, Addie Dolan, Sydney Clinton, and Katie Lothrop. And Katie's one of our General Thoracic Core Group members. So thanks everybody for joining. First, we're going to have some STS updates, STS education, and then a time for Q&A. Ruth is running the slides and she's doing a great job. I'm just all over the place. Okay,
no,
next
I'm doing
slide,
a horrible
please.
job.
Sorry.
Thank you. Sorry.
No, you're doing fine. You're good. All right, next slide, please. Okay, just a quick update on the STS support plan. Please reach out to STSDB_help desk at sts.org for any questions related to your participant report, IQVIA dashboard, IQVIA login. For questions related to contacts at your site, and other general questions related to the database in general, please reach out to stsdb@sts.org. STS is managing Tier 1 support for the help desk now, so your questions will come into us, and then we'll be able to either quickly get you answers or get the questions over to the right folks to help answer those. When you're entering a question for the FAQ mailbox, please ensure that the correct version and database are selected. Another thing to note is please make sure that in the sequence number box, you only enter letters or numbers, no special characters like commas or ant signs or parentheses, just letters and numbers only in the sequence box. Otherwise, it will get rejected. Okay, next slide, please. And here is our STS updates. The spring 2023 harvest closed on March 3rd. The report that was just this past Friday. The opt-out ended yesterday. We are finalizing the opt-out list to get them sent over to IQVIA. Once we have that over to IQVIA, IQVIA will prepare the data and send it over to STS Research and Analytics Center for the analytics to be performed. We're expecting that report to be available early summer 2023. We don't have a date yet. We'll know more once the data is transferred from IQVIA to STS for the analytics. GTS Public Reporting. Currently, the public reporting page has fall 2022 harvest data on it. The next refresh is expected in fall winter 2023 and will include the spring 2023, this analysis that just closed on Friday. It will be updated in the fall winter of 2023 with this data. Any questions you have related to public reporting, please reach out to publicreporting@sts.org. And my last update is the March training manual and FAQ summary should be posted by the end of this week. Early next week, depending on when Leanne, depending on what Leanne's schedule is, she'll get it posted as soon as possible. And I think that's all I have, Ruth. Now it's your turn.
Perfect. Thank you. We'll see if I can click forward on the slides and talk.
You did great. You did great.
Whole new world for me. Okay, so just a few updates that will be coming in the March 2023 training manual. There are more than this, but this is some of the highlights. We have talked extensively about lab values and how we abstract those, partly because there was a high number of mismatches during the last audit. After some additional conversation, the decision was made for both last creatinine and last hemoglobin that those values can be used if it is clearly documented that they were drawn prior to the infusion of fluids on the day of surgery, regardless if the patient is under the care of anesthesia or not. If it's not clear whether fluids have been started or not, then do not use a hemoglobin or creatinine obtained after anesthetic management has started. I've gotten this question a few times in the last, like, bumping right up into harvest. So how do you code a segmentectomy that's followed by a lobectomy? So sometimes what'll happen is they'll do this segment. I don't know if you can see my pointer. Can you see my pointer? Maybe, maybe not.
Yeah, I can.
Oh, good.
If you go down, yep, you got a thumbs up. Look at that.
Oh, good. So if the segmentectomy is performed in the mass, sort of like butts right up on the edge of it, sometimes what'll happen is they'll go back and do the lobe during the same procedure because they don't have a clean margin. There is not an easy or really a good way to code this. So what you do if the same lobe as the segmentectomy was performed on is resected in the same case, is you just do not enter the segmentectomy, you'll enter the lobectomy only. If it's a scenario where you have a lobectomy and a segmentectomy of different locations, you can code both. Sequence 1620, clinical staging methods. So in November of 2022, we made a change to the way that EBUS is captured to indicate that EBUS should be captured in all instances where EBUS is performed, including EBUS without biopsy, EBUS with a non-diagnostic biopsy, and EBUS of N1 or N2 lymph nodes. What was implied in that definition, but not explicitly stated, is that we assumed that the EBUS was performed in evaluation of the mediastinum. There are some cases that have been submitted where sites are doing radial EBUS only with the intent of locating a peripheral tumor, usually to dye it prior, like dye localize the tumor prior to resection. And those you would not capture as being EBUS for mediastinal staging purposes because they didn't even look at the mediastinum. There was no evaluation of the mediastinum whatsoever performed after reviewing those notes. And so while it is true that all EBUS is captured, the intent is really mediastinal EBUS. Sequence 4110, delirium. So delirium can also be termed acute confusional state, toxic or metabolic encephalopathy, or acute brain failure. And then I actually added this link to this NIH document in the training manual, and it gives like a nice sort of like 2-pager on delirium education, and you can click on that if you would like. And that is the extent of my updates for this timeframe.
Thank you, Ruth. That was very helpful. Is that link in the training manual?
It is.
Wonderful.
And hopefully
Okay.
they don't change it because I feel like I put links in the training manual and then sometimes the government likes to switch it up on us.
Yeah, and just let us know if that if the data managers could please let us know if that happens. That way we can update the links, as we're not checking them every day. And sometimes those links just disappear somehow. They no longer work. Okay, ready for some questions?
Sure.
I'm going to do my best at answering these. The first one, or I'm going to do my best at reading these. The first one I can help answer as well. It comes from Beth. One of our clinical champions asked if STS endorses a quality of life tool for lung cancer surgery patients. He is thinking about a future project utilizing a QOL tool and would like to use one that STS would approve of. Do any other STS sites use a quality of life patient reported outcomes tool? Thank you. Do you want to answer that one, and I could add in from the STS side of things?
I honestly don't know where the STS is currently at on patient reported outcomes. I know that that's a huge passion of Dr. Fernandez and that there's been lots of ongoing conversation. I don't know of there's not a PRO tool that's been published in the training manual today.
Yeah, I don't have much to add to that. That's exactly right. It's just we have a workforce or a task force that's working on quality of life, and hopefully we have something out soon. We don't have a tool that STS endorses though. And Beth, I think that's probably the best answer we can give right now. And your question about do any other sites utilize a QOL, if you wanted to put your email in the question box, if anybody wants to reach out to you with any quality of life tools that they use, you can certainly do that. When will we be getting STS benchmarks for pulmonary resection cases as we do for lobectomy? That's a good question. I didn't know that they weren't there yet, so I'm probably not the best one to answer. I thought that we already had benchmarks for lobectomy or for pulmonary resections, but I guess we don't. So hopefully soon. Ruth, do you have any input on that one?
No,
No. Okay.
I can investigate.
Yeah, we can certainly find out and report back. Let me see if I can, hold on one second. Okay, are there any plans in place to include a list of patients that will be analyzed when you submit harvest? Not that I know of, but if you want to send that over to Leanne, we can add that into the elaboration discussions with IQVIA to discuss in the future. Regarding the lab values, if the patient is an inpatient and has been on IV fluid, should we use the admission lab values?
Yes, you can use lab values that were obtained prior to the administration of IV fluids. Most likely they were within 30 days of the surgery. Overwhelmingly for your elective lobectomies and your elective esophagectomies, they're not going to have been in the hospital for an extensive period of time.
So I see when I go into the IQVIA platform, I see we have the lobectomy composite rating, the lung cancer resection, which is the pulmonary resection composite rating details. And then I see underneath the legacy reports, which is all esophagectomies, all segmentectomies, all pneumonectomies, all lobectomies, all wedge resections. Do you know exactly what they're looking for, Ruth? Because I'm not sure that we report anything different for lobectomies at this time versus pulmonary resections. And I'm happy to share my screen if you'd like.
Sure. I'll stop sharing if you want to share.
Okay.
I'm not exactly sure what the question is.
Okay. It was a question about benchmark reports. When will STS be getting STS benchmarks for pulmonary resections cases as we do for lobectomy cases? Is it in this section, Linda, or are you talking, I'm sorry, could you clarify that question? Is it in this section, the risk adjusted results with the STS benchmarks, or are you looking at the participant dashboard? I'm going to skip over clinical question right now, or that one. It says patient initially diagnosed in early 2022 and late 2021 underwent adjuvant chemotherapy and radiation therapy and was scheduled for esophagectomy 2022. However, another surgical procedure delayed ultimate resection. Repeat PET scan showed no evidence of disease progression, but there was still uptake within the distal esophagus. Esophagectomy was performed. Should this case be abstracted, or is this considered recurrent and not new primary? Did you want them to submit that to the FAQ mailbox, Ruth?
Yeah, that would be great. Thank you.
Thank you. All right. For clinical staging, what is the best way to capture EGD?
I am not 100% sure what you're asking. Like where do I find my EGD notes? Is that the question? What is the best way to capture? Katie, do you understand the question?
I think they're wanting to know, like, for clinical staging, like EGD is not an option for esophagectomies. So how would they capture it? But I'm thinking it's not captured.
Oh,
There's no option for it.
Thank you. similarly to that, not every type of clinical staging is captured for lung. So for example, CT guided needle biopsy of the tumor is not captured for clinical staging of lung. It's not intended to capture every type of clinical staging possible.
Thank you. Our department chairs want to submit all hernia and GERD procedures. Will these be analyzed by STS? I'll let you take that one, Ruth.
So hernia cases aren't analyzed, they're benchmarked. So they've never been risk adjusted. There's not a risk adjusted model for hernia. I know that it is under consideration as maybe a future opportunity. If you submit your hernia cases, you will get benchmark data back. You can see on Carol's screen currently the benchmark reports for right there, fundoplication, paraesophageal, and routine hernia.
Somebody's asking, I guess that question, they're trying to clarify the question is, will they get risk adjusted numbers for pulmonary resections? And do we already get risk adjusted numbers for lobectomies?
For
I mean, I can see
lobectomy,
composite rating details, but do you get?
There's some, let's take that one offline. We can follow up at the next webinar in 2 weeks, and we can give an overview of everything that's available for pulmonary resection.
Okay, sounds good. Thank you.
I can follow up with Linda and make sure that I understand her question completely.
Okay, thank you.
Joseph, I have your question in the FAQ mailbox. I think I got it a couple days ago. I will respond to you there. If a patient does not get anticoagulation at home, but did get it into the hospital prior to procedure, is this to be counted in pre-op evaluation? I'm sorry, because of the way my screen is, I can't pull up the training manual. It's making answering these questions really, really hard.
Well, we could pull it up right now.
As much as I read the training manual and write notes in it, I don't have it memorized.
I guess we're looking underneath the preoperative medication.
I would imagine within 30 days prior to the principal operative procedure. I guess we don't specify, so if you can send it into the FAQ mailbox, that would be great.
And do you want to try to take this, the last question that's here? It says a patient was diagnosed in 2018 with stage 4 EGFR mutant lung adenocarcinoma on targeted therapy since 2018. He has stable disease on first line, dose reduced till present. Now January 2023 presents for a surgical evaluation wedge resection. Pathology was YP T1B N0. Is this a recurrence? If not, shall I use stage 4 from the 2018 as the clinical staging? Is that something you'd like to send into the FAQ mailbox, Ruth?
Yes, that would be best because I will likely need more notes. I'm sorry.
Okay, no problem. Thank you. And then I see one person with their hand raised, so I will unmute you if you'd like to try to unmute yourself and ask your question. Feel free to. Did you like how I skipped over the tricky words in that one?
Well done.
Thank you. Okay. I don't see 18150. I'm not sure who that is, but I don't see that you're unmuting. If you want to go ahead and try to unmute. Otherwise, I don't see any other questions. Ruth or Katie, did you have anything? Or Sydney, Addie, did you have anything you'd like to share?
Not at this time.
Emily Conrad, nothing.
Nothing from me.
Okay. Oh, in IQVIA, do the legacy reports include non-cancer resections or are they just cancer resections?
I'm
I think
sorry,
it's all
what was the question?
in the legacy reports on IQVIA. So these reports here, are these primary lung cancer or are they all procedures?
If you click on it. Oh, no, it'll be in the, sorry, I'm lying to you. It's in the analysis overview document that's in the IQVIA library. It'll tell you exactly what makes up each report. I believe it is my most favorite tool because trying to remember what goes into every report
Let's see if we can find it easily here.
is not.
Benchmark legacy reports.
So the esophagectomy benchmark legacy report includes those specific procedures,
And okay.
not married to a diagnosis code. So if you go up and contrast that against the lobectomy risk adjusted score, you'll see it marries the primary procedure to a diagnosis. So here, right there. So go up just a titch. So the lung cancer cases are patients with a primary category of disease of lung cancer, and then one of the following procedures.
Karen says, thank you so much. And then Nitin is asking, can you please show how to get a DQR using IQVIA? It's a little bit more complicated than just one report. I don't know if you want to walk through that, Ruth, or if you, I'm happy to try to do it, but.
I'm not gonna be able to demo it off my screen. Can we cover that topic at the user group call?
Yep,
Let me
absolutely.
have it all ready to go.
Yeah.
And if you're interested, I think, Katie, that was part of your presentation that you put together just recently that should be recorded and out there on the SCS website as well. If you don't want to wait, we'll definitely redo it in 2 weeks for the user group call, but I think it's already out there. Do you remember the date of that presentation offhand, Katie?
The one where I went over the analysis or the one regarding a data quality report?
I thought you did data quality reports, but perhaps
No.
I'm calling incorrectly.
Yeah, I
Maybe
didn't do
Leanne
anything
did that one?
regarding that. No, I didn't. I might have been Leanne. It wasn't me.
Okay, Leanne might have done it. I'll try and find the recorded session and send it to you, but we can go over that in 2 weeks.
Yeah, let's go over it again. Okay.
Yep.
I
think Katie's video that she did on analysis overview is already part of the library. It should be in there because it was one of the webinars that we did. I think.
So
Yeah, it was there. I don't know if you archived them at some point, but it was there.
yeah, they go. It was probably one of these, either the February, I think it was the February 8th.
They stay out there
webinar.
for a long time though.
And then we have this GTSD webinar playlist that houses all of our previous webinars. Lots of good information here. I wish we could have these cataloged a little bit better, but it's really hard for us to keep up with everything.
Dion says it was February 22nd.
Yeah, thank you, Deanne. And Leanne did, the last webinar was on the data cleanup. Okay. Anything else? Anything else you guys want to talk about? Y'all want to talk about? Anything, Ruth?
No.
Any exciting news? Okay. All right. Well, then I guess we can go ahead and end early. Thanks everybody for joining. I hope you have a great rest of the day. Thank you, Ruth, so much for all your work on the database.
No, thank you.
And thank you, Katie, for joining, and thank you, my STS colleagues.
Bye.
All right. Take care, everybody. Bye.